What's up, everybody? It is the PA Professor, and today we are going to cover bundle branch blocks, both of the bundle branch blocks. This is not a super high yield topic for the PANCE, EOC, EORE, stuff like that, but I cannot guarantee that you will not get a question about EKG interpretation on bundle branch blocks. So let's just go ahead and hit the whole thing and hit all the high yield information that you must know. Okay. So my high yield definition was I saw a bundle branch block as when conduction is delayed or blocked in one of the bundle branches. So we know in normal physio, the SA node fires with its automaticity. It goes around the atrium to the AV node to the bundle of His, and then it goes down each bundle branch. And then you get simultaneous ventricular contraction. But what happens in a bundle branch block, you see we have two types, left and right. If you have, and two types, not three, you can't have both because then you're dead at that point, but you have left and right. So if you have a left bundle branch block, your impulse gets to the bundle of His, it starts going down both bundle branches, and then boom, it gets stuck at the left. But what happens is the right keeps going, so the right ventricular contracts before the left ventricle. But when the right ventricular ventricle contracts, there's kind of like this Purkinje fiber connection right here that shares this impulse, and then the left ventricular delays, but it does end up contracting after the right ventricle. So that's in a left bundle branch block. In a right bundle branch block, it's the exact opposite. The impulse makes it halfway down the right, it stops, and then the one that went down the left bundle branch continues to go, and it causes left-sided initial ventricular contraction, and then it shares it right there, and then you get right ventricular contraction. So in a right bundle branch block, the left ventricle contracts first, and then the right ventricle is delayed, but it does contract. So that's kind of the physio and patho of what's going on in these bundle branch blocks. So what causes bundle branch blocks? Usually you see it in people with coronary artery disease, kind of like post-MI scarring and fibrosis that affects that ventricular septal wall, the area where those bundle branches are. This is kind of what causes this etiology. Symptoms, of course, if you're not beating properly, especially on the left side, that's going to systemic circulation. You can have syncope, pre-syncope. You can also have lightheadedness because that pump is delayed. You can also be fatigue, stuff like that. But that's not your super high yield. Your bread and butter that you need to know for bundle branch blocks in PA school is this workup, your EKG interpretation. You must be able to interpret the EKG findings for a bundle branch block. So let's do it. When you look at bundle branch blocks, there's two leads that you need to focus on. Obviously, when you get the EKG, you're going to look at all of it. But if you look at it and you're still not sure, and you're maybe wondering if it's a bundle branch block, look at V1 and V6. So there's a saying that we learned in my PA school from our professor who was a cardiologist, and she said, just remember William and Morrow. You can see that William has two L's in the middle. That is for a left bundle branch block, and Morrow is for a right bundle branch block. And what you're doing is the first and the last letter of these names are the shapes of your QRS complexes in lead V1 and V6. So if you have a left bundle branch block, which is right here, I believe, if you look in V1, your QRS shape should be in a W. Let's see. V1, yes, it's a W. 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 And in V6, in a left bundle branch block, you should see an M shape. Let's look. M, M, M. And these little divots in the QRS and widening of the QRS is because it's taking, right? It's taking more time for both ventricles to contract, which prolongates that QRS interval. And this is kind of where your block is right here. And then you finally get that delayed contraction. In a right bundle branch block, you remember Morrow. So in V1, in a right bundle branch block, your V1 QRS should be shaped like an M. Let's look. M. M. And then in lead V6 in a right bundle branch block, your QRS should be shaped as a W. Let's see. W. Yep, W. And it takes a little bit to fixate your eyes on this and kind of remember it. But once you get this, you should be able to interpret these EKGs quite easily. If you see this in V1, V6, you have some sort of block, like this notch, excuse me. So then you just have to decipher what shape these are in. So this is your bread and butter. I can't stress that to you enough. You need to know how to read these EKGs. Treatment. So you diagnose someone with a heart block, right? Is it left or right? Well, right, since it's not going to systemic circulation, can be asymptomatic, and observation can be okay with like a cardiology referral. However, if they are symptomatic, you need a pacemaker to get that big impulse to go through everything and contract your heart accordingly. Now, if it's a left is considered, I don't want to say it is more severe, but it's considered more severe because in PA school, you should be taught that a left bundle branch block is a STEMI until proven otherwise. And here's the reason why. Why is a left bundle branch block considered a STEMI until proven otherwise? Well, if we go to a left bundle branch block, if we look at V6, and a lot of times V5 will kind of be like this, what does this look like? That looks like your QRS. Well, what's that? Oh, no. Is that ST elevation? No, it's not in this case, but a lot of times left bundle branch blocks can be confused with a STEMI because it does look like you have somewhat of elevation right here. But, again, this is just why left is considered more severe. And a lot of times if you have a left bundle branch block, you send them to the cath lab, right? So that is why right there. However, this is what's going to be on your boards, I believe, if they ask you a question on treatment. If they ask you what is the definitive treatment for bundle branch blocks, it is a pacemaker. You need to know that. Okay, so with all this being said, right, let's do a high yield vignette question. A 76-year-old male presents with a weird feeling in his chest. Okay, probably need to do an EKG. Okay, here we go. An EKG is shown below. What is the diagnosis? Okay, so obviously this video is on heart blocks. Let's say it wasn't in this video and this is an actual patient that comes in. Let's look down at lead 2. That's where I start at least. You see these notches, right? Okay, and you're seeing widening of the QRS. It's not VTAC, but look, you end up getting to your precordial leads, and you see these notches. So obviously now you're thinking heart block. So what leads do you need to focus on? V1 and V6. So let's look at V1 and let's see what the shape of the QRS is. Well, right here, I'm seeing a M. I'm seeing a M. I'm seeing an M. This one's pretty obvious. Okay, so right there I'm thinking Monroe, right? Our right bundle branch block. But let's confirm it with lead V6. So go to V6. What do you see? I see a dip and then a W. W, and you see the W kind of right here too as well. So I've confirmed that this is a right bundle branch block. Okay, guys, if you like this video, give it a like. Subscribe. Again, bundle branch blocks are not the most high yield topic on the PANCE, EOC, EORE, but you do need to know the basics of it, and hopefully I gave you the basics right there. Thank you guys for watching. Good luck on all your boards, all your tests. You're going to do great, and we'll see you in the next video.